All right, so I think we left off with inflammation. We talked about, gave a brief description of what the function of the inflammation was, to pretty much restrict or quarantine the bacteria or the virus or the pathogen, whatever the bad thing was that was trying to get into our body, so that our immune system could fight it. All right, and here we're going to run through some of the events, some of the things that are going on during an inflammation that's trying to do this. And so the first thing is we get blood vessel dilation. So when we damage some sort of tissue, usually our skin, right, the blood vessels are going to leak blood into the area. If it's deep enough into the dermis where there are blood vessels, those blood vessels, the first thing they initially do is dilate, okay? And that's because some of the tissues in the dermis release a couple chemicals. Mast cells release two chemicals. Yeah, heparin and histamine, right? All right, one of them prevents the blood from clotting, and one of them causes blood vessel dilation. Do you remember which one does which? Histamine's dilation, and heparin reduces the clotting. Good. Okay. We get an increased permeability of the capillaries. That simply means that things are able to leak out of the capillaries more easily. Okay. And so these two things right here, what they're doing, the combination of dilating the blood vessels and letting things leak out of the blood vessels, usually white blood cells, okay, is to bring more troops to the fight in that area, okay, which makes sense. We get an increased blood viscosity because we get more formed elements there. The blood gets a little bit thicker in that area, which also would make it tougher for the pathogens to make their way into our system. All right, swimming through a pool full of water would be much easier than swimming through a pool of pudding. Okay. Area gets walled off. Okay, and this happens because we start to form clots around the area. So we're basically quarantining that area. We increase the blood to the area, and the blood brings heat with it. Okay, and so that heat sometimes denatures some of the enzymes that the pathogens need to kind of set up shop. So in a way, that increased temperature that we feel when something's inflamed is actually supposed to happen. It's supposed to help slow down the growth of that pathogen. We get white blood cell margination, which I think we mentioned last Wednesday. What did that mean? So the white blood cells have the ability to stick to the blood vessel walls and the capillaries and wait for those things to maybe try to get into our bloodstream, and they'll fight them. They'll prevent that from happening. We get white blood cell diapedesis, sometimes called emigration, which is, I think we mentioned once again, this is the white blood cell's ability to leak out of the blood cell or blood vessel and migrate to wherever the infection is, to wherever the fight is taking place. We get white blood cell and macrophage aggregation, which means they're drawn to that area. Okay? There's chemicals released that kind of signal them to come to that area. Those chemicals are called cytokines, and they draw these white blood cells to the area to fight. We get phagocytosis. Okay? Phagocytosis is generally they're trying to engulf and destroy. They punch holes in the membrane of the pathogen, inject a little what's paramount to about hydrogen peroxide, and they blow it up, and then they take what they destroyed and present it to other white blood cells. So we might start to produce antibody or whatever we need to fight that particular fight. And then at the end, macrophages will clean up the area, get rid of the dead bodies, the dead cells, the dead pathogens, and we'll probably have the fibroblasts deep enough there, we'll start to lay down scar tissue to replace those dead cells. Okay? So here's looks like a really vicious stabbing with a splinter, and it breaks through. This was the epidermis, right? Stratum basale was right there. So now we're in the dermis. It had bacteria on it. It introduces the bacteria to our body. Okay? we release those cytokines, and that's going to start to draw cells to the area. They're going to move via diapedesis or chemotaxis to that area. Some are going to do the margination and just hang out here, and they're going to start to destroy, phagocytize that bacteria. Okay? Present it to other immune system cells if necessary. Mast cells are the ones that started to release some of those chemicals, not only the cytokines, but the histamine and the heparin. Okay? Then, so initially with any kind of wound, what we're going to see is blood vessels dilate, the blood doesn't clot initially, but then very shortly thereafter, the clotting factors do initiate clotting, and we stop the bleeding. Okay? So some of the inflammatory chemicals include what's called bradykinin. Okay? Bradykinin's function is to cause pain, because pain is kind of an important thing. It lets you know there's a problem. If you didn't feel pain, you'd never know there was anything wrong. It increases vascular permeability and facilitates that chemotaxis, bringing the white blood cells to the area. Bradykinin causes an intense type of pain. It's, I think it's bradykinin or something very similar that scorpions inject when they sting you. If you've ever been stung, who's been stung by a scorpion? That hurts, doesn't it? That is horrible stuff. I hate those little things. Okay? Complement, another chemical, increases phagocytosis and promotes more chemotaxis. Histamine, released by the mast cells, we already knew that, and basophils can release it. Increases the vascular permeability. Serotonin increases more vascular permeability. So you see these inflammatory chemicals, for the most part, are all increasing vascular permeability. Some do a little bit more with chemotaxis and actually drawing them to the area. Some kick up phagocytosis a little bit. Oh, sorry, I didn't mean to go so fast. And oftentimes during this inflammatory process, what we're going to end up with is what's called an abscess. Okay? This is, we've quarantined the area off. We've contained, in that picture with the splinter, we've contained the bacteria, and we walled it off, and what we find in there is, go back, sure. Don't worry about it. So we end up with what's called an abscess, which is the quarantined area filled with the dead fighters. So in that case, it was bacteria. So we'd have dead bacteria, we'd have dead white blood cells and macrophages in that area, and we'd call that pus, okay? So there'd be dead neutrophils, dead macrophages, dead white blood cells that came to that area, fought the fight, okay? An abscess in the real world gets kind of confused with this other thing, because this is kind of like splitting hairs with the textbook, a granuloma. A granuloma was prior, so first you had a granuloma, then it became an abscess. The difference being the granuloma still had live bacteria in it, okay? The abscess, the bacteria or the virus or whatever, was killed, okay? So a granuloma that has living bacteria in it is dangerous to open up. Okay, because that would allow the bacteria then to spread. So oftentimes in the real world, they're going to use just the word abscess. Okay, so if somebody's using abscess in a hospital setting, they're probably warning you that it's more of a granuloma and that there's live bacteria, and you have to be careful with that. Okay. Hemostasis. So this is a fancy term for basically stopping any bleeding that we have going on. Okay, so we encourage bleeding initially to bring white blood cells to the area, bring immune system cells to the area to fight the fight. Then we want to stop that bleeding because we only have 5 liters of blood, give or take. We don't want to lose it. Okay, and this happens when blood vessels are damaged or ruptured. And when we get a cut, if I got a cut on my arm and we started to have it stop bleeding, we started to have it clot, what can you tell me? Is that something that's widespread throughout my body, or is that localized? Localized, and that's very important. I don't want to cut here to cause clotting all throughout my cardiovascular system. That would probably kill me, right? Okay. So this response to stop bleeding, we want it to be quick because we don't want to lose any more blood than we have to, and we want it to be localized. We have to have it carefully controlled by the body. And there's actually two pathways that will get us there. There's an intrinsic and an extrinsic pathway. Either one will get us to blood clotting. The steps involved, we've got what's called vascular spasm. What's that mean to us? The blood vessels are going to constrict, okay? They're going to tighten down, clamp down. Then we have platelet plug formation. What's that sound like is going to happen? Yeah, we're going to make a plug out of platelets, okay? And then blood coagulation or clotting, okay? So the names, and the reason I do that, I realize that you guys could do that on your own, but sometimes we get so caught up with writing stuff down that sometimes it's not that hard. The name kind of tells us what's going on. So, vascular spasm, just what we thought. Now, is that skeletal muscle, cardiac muscle, smooth muscle that's clotting? Constricting. Smooth muscle in the blood vessel, good. All right. Contracts to try to stop bleeding. The platelet plug formation was just what you thought too. The endothelium, the inner layer of the blood vessel, starts to become sticky. And the platelets start to become sticky and they start to clump together and stick to the blood vessel wall. And they're forming a plug. They're forming a cork to stick in the hole in the blood vessel. This all starts with the release of, because it'll come up later with what's thromboxane. Okay, it's an enzyme that's going to promote clotting. And then we get to the actual part of clotting itself, where we convert that fibrinogen that's carried in the blood plasma to fibrin. Okay? And the best way I can describe this fibrin, think of it like a spider web. Okay? Strands going every which way that are sticky. So they help the platelets stick together and stick to the area where there's a damage. Okay? This is going to require numerous clotting factors. And we're not going to get super involved in that. There's, like I said, there's two pathways. They all lead to what's called the common pathway. We'll look at the common pathway a little more than the others. So the two pathways are the intrinsic and the extrinsic, and they come together as the common pathway. And it's kind of confusing because they number these clotting factors, but then they don't put them in numerical order. So it's not really that important. What you need to know about clotting factors, it's kind of a domino type thing. One clotting factor leads to the release of the next clotting factor to the next clotting factor to clotting, okay? So it's a series approach. So if you're missing one of those dominoes, if I had 10 dominoes lined up and I pulled one out, first, depending on where I pulled it out, the first few would go down and then it would stop, right? It wouldn't continue to knock it down because we're missing one. Who's missing clotting factors? What disease do they have? Hemophiliacs, okay? They're missing clotting factors. Phoenix Children has a huge hemophilia ward there where patients from all over the state come to get their quote-unquote factor. So they just synthetically give them their factor so that their blood can clot. So here we go. A little picture of trying to show us some of this. Vascular spasm. I don't think we needed a picture for that, but we cut the blood vessel. The smooth muscle is going to constrict to try to decrease the amount of blood loss there, okay? If this is the damaged vessel here, we're going to get platelets that are going to clump together, stick together, and we're going to try to plug up that area so we do not lose any of the blood. Those are those two phases. And then the most important one is going to be the actual clotting. So here, they're showing a damaged vessel. As the blood passes through it, these roughened ends damage the cells enough that one of the pathways, the intrinsic pathway, is going to be activated. Okay? So one factor, the intrinsics, the clotting factors through the blood. The other is the extrinsic. It's more from damage to the cells of the vessel or tissue around it. Okay, so when we damage that, that's going to trigger the release of thromboxane. We're going to turn fibrinogen into fibrin. And it's, like I said, it kind of looks like a spider web. The platelets get stuck up in it, and it plugs up the vessel and stops the leak. Okay? Now, we also know, even though we haven't said anything, is that going to stay clotted? No, it's going to be a short period of time until we fix this, and then we're going to want the clot to dissolve, right? Because we don't want that breaking off and floating through our cardiovascular system, right? What would that be called? If it broke off, you're on the right track. But if it broke off, now we'd call it with an E, embolism, an embolus. Okay. All right. So clots. It's a gel consisting of insoluble fibrin. Okay, and the formed elements get trapped there, particularly the platelets. We arrive at this clot formation through the release of clotting factors. Okay, these are simply the chemicals that have to be in the sequence to get the blood to clot. Some are released from the damaged tissue cells, so not from the blood, but from the tissue around where the cut took place. And this would trigger the extrinsic pathway. And some are released by the platelets themselves. Some are released by the blood plasma. Either way, the platelets and the plasma are part of the blood, so that's considered now the intrinsic pathway. Okay? And so both of these pathways are going to lead to what's called the common pathway, and they call it a cascade. When it's this domino type thing, one thing leading to another, they call that oftentimes a cascade. So let's see, involves a cascade of reactions divided into 3 stages. Okay? We activate, and we're looking at the common pathway. So we're not going to get into what happens in the cascade for intrinsic or extrinsic. I'll show you, but we're not going to worry about it. We're worried about the common. So we either had damage, the blood vessel, the platelets or the plasma started this clot, or the damaged tissue started this clot. Either way, we got to what was called the common pathway that they're both leading to. And we activate what's called factor 10. Factor 10 leads to the formation of prothrombinase. Prothrombinase used to be called prothrombin activator. Okay, prothrombin activator told us exactly what it was going to do. It's going to activate prothrombin. And when you activate prothrombin, you turn it into thrombin. Okay, remember pre-pro, always the precursor to something else. So prothrombin was the precursor to thrombin. And when thrombin's released, it converts soluble fibrinogen into insoluble fibrin. That's the common pathway, okay? Activate clotting factor 10, which they like to use Roman numerals, so clotting factor X, capital X, okay? Leads to the formation of prothrombinase. Prothrombinase turns prothrombin into thrombin. Thrombin turns fibrinogen into fibrin. The clotting cascade can be initiated. We can get to the activation of factor 10 through either pathway, intrinsic or extrinsic. Okay. So clotting pathway. The intrinsic pathway is the slower of the two pathways. So the initiation of trying to get to factor 10 through the platelets or the factors in the blood plasma is a little slower. It takes about 3 to 6 minutes. Okay? These factors are located within the blood, bless you. Okay? And usually happens because the blood is passing through a roughened surface, usually from some damage to the vessel. Okay? And that's important to realize. Okay? If blood going over a damaged vessel, like that picture showed, it had the kind of the jagged edges and the blood went by there, and that's what agitated it and triggered this intrinsic pathway. Well, do you think it's possible that somebody could have plaquing in their vessels, hardening of their arteries, enough to cause enough irritation that that would trigger clotting? Okay? And that's probably what's happening when they develop thrombosis, deep vein thrombosis. They've got enough plaquing down there that, plaquing that we're starting to make these clots that shouldn't be made, okay? Because the body doesn't know any better. So from that lack of diet, lack of exercise, sets up that stage, okay? The extrinsic pathway, the clotting factors were not from the blood, right? They were from the cells or the tissues that might have been damaged with whatever kind of cut we had. So they're from an external source, some sort of tissue damage. And here, just, you're not going to have to know this. I'm just showing you to show you why it's kind of just mindless. It activates factor 3 plus calcium that gives us then factor 7 that gives us factor 7 tissue factor complex. Like the numbers and everything just doesn't make any sense. It's pointless to go into it. If you go into hematology, you can learn all that. We'll stick with just knowing the common pathway, which was what? We activated which factor first for the common pathway? Factor 10, which led to the production of prothrombinase. Prothrombinase turned what into what? Prothrombin into thrombin. Thrombin did what? Turned fibrinogen into fibrin. Good. Okay, so that's not too bad. Both pathways are used in hemostasis. Now, the extrinsic pathway takes about 15 seconds. Okay, so you get that cut, the blood vessels are dilated, the blood is not clotting for about 15 seconds to bring things to the area, and then we start the clotting process. Okay? All right, so this page here is showing us a little bit of the intrinsic pathway leading to the common pathway, but here's where the common pathway starts. That's why I have it on here. Factor 10 activated prothrombinase, otherwise known as prothrombin activator, turns prothrombin into thrombin. Thrombin turns fibrinogen into fibrin. Okay? And it has like an amplification effect. A little bit here leads to a lot here. Okay? Here's another picture. This one is showing an intrinsic pathway over here. So the same factors we just saw. Here's the extrinsic pathway. All right? Ultimately all leading here to factor 10. Factor 10, this is what we just went over. Factor 10, prothrombinase, prothrombin to thrombin, thrombin turning fibrinogen into fibrin, and we make that clot. Okay? So I'm not going to ask you the steps in the intrinsic pathway. I'm not going to ask you the steps in the extrinsic pathway, but I might ask you the steps in the common pathway. Do we get that there's two pathways? They all lead to factor 10. From factor 10, this is what happens. Okay? So, some other things. Blood clotting requires vitamin K. It also requires, and then I really didn't emphasize it, but one of the things you saw was factor 3 plus calcium. So calcium is also something that's needed for blood to clot, but vitamin K is as well. Vitamin K is needed for to produce several of the clotting factors. Pregnant mothers, they supplement them with vitamin K. Vitamin K is for the baby to prevent hemorrhage, brain hemorrhage. Okay? So vitamin K is necessary to synthesize 4 of the clotting factors. The other thing that happens with the clot, so we've got that webbing of fibrin, we've got the platelets and the cells that are caught up in it. The other thing it does to really seal it off, it's called clot retraction. It's almost, think of it almost as tying your shoelaces. When you pull your shoelaces tight, you pull that webbing and everything tightens up so that there's no leaking, okay? So blood clotting involves clot retraction, tightening of the clot, okay, kind of almost a contraction of that fibrin. And then, and you guys already told me this, we have to lyse the fibrin, fibrinolysis. Lysis means we destroy it, right? So we do that to break up the clot. If we do that, so you've got this clot, it's platelets, they're clumped together, they're stuck in the fibrin. If we have something to destroy the fibrin, then the cells are just going to fall apart in that clump. They're just platelets. They're going to go back about their business and start floating through the cardiovascular system, and everything's going to be fine. Okay? So the fibrinolytic system dissolves small clots and clots at the site of damage once the damage is repaired. Okay? What does this? There's two names for it. They call it fibrinolysin or plasmin. Okay? Different books, different hospitals, different places teach this stuff. We'll use either name, plasmin or fibrinolysin. Once again, fibrinolysin is a nice, very descriptive name. It tells you exactly what it's doing. It's destroying the fibrin. Okay? Plasmin's not as descriptive for you. Okay, so it's synthesized from plasminogen, and it dissolves a clot by digesting the fibrin threads. Breaks down that fibrin, and then releases the cells that are caught up in it. Plasmin also inactivates substances such as fibrinogen, prothrombin, and factors 5, 8, and 12. So basically what it's telling you there, not only does it break up the clot, it throws a wrench in the work of making any new clots, right? So plasmin, or some sort of synthesized plasmin, something like it, would be what they might want to give somebody that did have clots, right? Because there's a chance that it might help break up those clots, okay? Once again, you see how kind of the medicine stuff works. They find things in our body or whatnot that do a certain job, and then if they can, they'll use it to other times when they think it might be appropriate that would help. They'll make more of it. They'll patent it, whatever. Give it to us to try to keep us alive. Any questions on that? Okay. So clots are generally localized due or controlled by, there's one other concept that happens here. Fibrin absorbs thrombin into the clot. So thrombin was the substance that did what? Turned fibrinogen into fibrin, right? So once it's turned into fibrin, the fibrin has the ability to absorb some of that thrombin. If it absorbs it, then it can't turn fibrinogen into fibrin. So the more fibrin we get, the more it absorbs the thrombin. So see how it's self-limiting? The bigger it gets, it's going to absorb more and more thrombin, which means the thrombin isn't going to do its job and make the clot any bigger. So that's how we keep this clot formation on kind of a smaller level. Does that make sense? Which is good. We don't want these things to get out of control. If they do, that's a problem. Okay? I got a brother-in-law that's in a hospital in Michigan who had a golf ball-sized clot in his leg. They had to just amputate his leg on Thursday. So when these things get out of control, it's a problem. It's a huge problem. Production of prostacyclin, a powerful inhibitor of platelet adhesion, is another substance that can be released. Okay? This obviously is going to keep the platelets from sticking together. So any kind of anticoagulant kind of does this. It makes the cells less sticky. Now oftentimes they'll say it thins the blood. That's not really what it does. It keeps the cells from sticking together. Anticoagulants, substances that inhibit coagulation, such as heparin, can be given. Heparin used to also be called antithrombin. Okay? Some of the previous names seem a little easier. I think people got through school and said, this is easy, let's make it hard for everybody else. So we'll change the names on them. Okay? Any questions on that? It's not too bad if you guys can focus here on an early Monday morning. All right, so clots sometimes form elsewhere in the cardiovascular system that we don't want to have happen. They do it abnormally. And we already know what that's called. That's a, the T, thrombosis, right? So that's abnormal clotting. Okay, that's what my brother-in-law had. He had this abnormal clot forming. Okay, so now we're getting clotting in an unbroken blood vessel. Shouldn't happen, but for whatever reason it does. The thrombus is the clot. So thrombosis is the process that we form a thrombus. A thrombus is the actual clot, a blood clot attached to a vessel wall. It's often attached to fatty plaques, okay? Thus, the atherosclerosis may be leading to more of this clotting. When it breaks off, we call it an embolus. Okay, an embolus is this thrombus floating through the bloodstream. Okay, and as we mentioned before, as you guys know, if these develop primarily in the deep veins of the calves, the vessels, as they move upward, only get bigger and bigger in their diameter towards the heart. So it's easy for them to get to the heart, where they'll get pumped to the lungs, where the vessels are narrow, or where they'll get pumped out the left side of the heart, out the aorta, where eventually the vessels are narrow, and they'll get lodged somewhere in there. Okay, maybe they get into the coronary arteries, and then they lodge in the heart. And then that would lead to an infarct. Do we know what an infarct is? Death of a tissue due to lack of blood supply, basically lack of oxygen, right? All right. So that's going to take us to blood typing, or blood groups. Looks like we're still writing though, so I'll wait a second. Okay, so what do we know about blood groups? Have we heard of any blood types? What are some blood types? Type A blood, type B blood, O and AB. There we go. What's that positive and negative mean? They're a good person, bad person? Maybe. We'll see if we can figure that out. So, red blood cells, the actual cell has antigens on its surface. Okay? If the blood has a specific antigen, like a type A antigen on it, then we're going to call it type A blood. Okay? That's some complex stuff. Give me to repeat that. If the red blood cell has an A antigen on its surface, not in the plasma, on the cell surface, then it's A blood. If it had a B antigen on it, what would you call it? B blood. Nice. There we go. This is easy. All right? So, the blood groups, or the main one, there's different ones, this is the most common, is based on the presence or absence of these antigens. Okay? Throw you out a tough one now. Let's say the red blood cell didn't have any antigens on it. What would you call it? O blood. There we go. Good. So, within a blood group, there may be two or more different blood types. And this is telling you, there's other blood, Lewis, Kell, Kidd, there's different ways of doing blood. This is the most common. I don't even know who uses the other ones, but maybe somewhere you guys will go far enough in your education that you'll learn. Okay, so the major blood groups are A, B, O, and Rh factor. Okay. Pardon me. So the Rh factor is what's going to tell you if they're positive or negative. Do they have Rh factor? They're positive for it. Do they not have Rh factor? Then they're negative for it. Okay? So, and here's the other blood groups. Lewis, Kell, Kidd, Duffy, whatever. So if you see those terms, they're talking about a different type of blood grouping. Okay? Now, here's another little wrinkle they throw at you. Antigen is a more common term. I use antigen. Some books will use what's called an agglutinogen. Okay? Antigen is the same thing as agglutinogen. All right? I think the person that did our blood lab, when we get to it, at one point was using agglutinogen. So you've got to keep those straight. That makes me do a double take to figure out, okay, agglutinogen, what the F is that? Okay? So we have two types. We have A and we have B. And we just talked about it. If it has A on it, it's going to be A blood. If it has the B antigen on the red blood cell, it's B blood. If it has both of them on there, then it's going to be AB blood. Okay, cool. On the red blood cell surface. That's important. Underline that. Circle that. Okay? Now, we switch from the red blood cell. Now we're going to talk about the plasma. Okay? Now, we have to understand antigen-antibody and how that works. Antibody specific to a specific antigen does what to it when it sees it? Kills it, right? Everybody agree? All right, so if I have type A blood, will I have type A antibody in the plasma? No, can't. Because if I did, it would attack the red blood cell, right? Kill it, destroy it. Okay? It would clump together and then destroy it, break it up. All right? So that's a fact you have to keep in mind. When you have B blood, you know absolutely positively you're not going to have what in the plasma? B antigen. Okay? If you have type AB blood, what antibodies are you going to have in the plasma? None. Good. If you have O blood, we know we don't have either the A or the B antigen on the cell, so we probably have what in the plasma? A and B antibodies. Got that? Because it's simple. When you have it, it's simple as hell. And I've watched so many students get just torpedoed by this blood grouping typing thing. Okay? Okay, so this helps determine our ABO blood types. The plasma contains antibodies. Once again, I think the person that made our lab liked to use agglutinogens and agglutinins. All right? They're meaner than I am. But they're the same things. So, designated A, anti-A, and anti-B. So, I don't call them anti-A, I'd call it B antibody. B antibody means it's anti-B, means it kills B. All right? So, these react with antigens foreign to the individual. Yeah, anti-B means the same thing as saying B antibody. So these antibodies react with antigens that they think are foreign, okay? And they'll destroy them. And they do this by clumping and basically lysing, destroying the cells. They call this process agglutination. All right. So just to make sure, where's my smelly good marker? If I have a red blood cell and we're going to draw something that looks like an A, we're going to call that the A antigen. Then what type of blood is this? No, it's A blood, because we name it for what antigen is on the cell surface. What antibody does it have? And the B antibody, now this is on the cell surface, right? This is where? Plasma. So you got to keep that, that's an important concept to keep in mind. Where are the antigens and where are the antibodies? All right? If I have this one here, and we're going to draw its antigen that looks kind of like a B, then what type of blood do we have? B blood. And we're going to have what type of antibody? Okay, yeah, kind of running it all together, but you get the picture. Antibody. All right. If I have one here that doesn't have either the A or the B antigen, then we call it what type of blood? O blood. And it has what antibodies? A and B. They use AB as the abbreviation for antibody. And then if I have this one here, the last one, and it has both antigens on it, then this is now AB blood. And it has what antibodies? No antibodies. Okay? And this is how they type them. All right? The only thing we haven't put in there yet is the Rh factor. So, it's a given that when you have B blood, you're going to have A antibody. If you have A blood, you're going to have B antibody. This is a given. This is done. If we put a sample of B blood out there, and I said what antibody's in it, you wouldn't have to test it. You know right off the top it has A antibody. Okay? These are givens. Rh factor is not quite that way. Okay? So we're working our way towards that. So there's our blood types: A, B, O, and AB. Okay. So here's a little bit of what that agglutination looks like. Here we have a surface antigen. They're not really telling us what's called. For our pictures, that'd be A. And then they put it with some A antibody. These things attack the blood cells, they clump together, and then they blow it up like the Death Star. Okay? Here's their pictures. Their pictures aren't as good as mine. But if you have A blood, type A blood is going to have anti-B, or we just call it B antibody. Okay? Type B blood has A antibody. Type AB has neither. Type O has both. Okay? So that takes us to, what's the question? Sure. That one or one more? One more. Is that an RBC right here? This is an RBC, this is an RBC. These are antibodies in the plasma. Okay, good? All right, so now we get to the Rh factor. And I've already told you, Rh factor, if you're positive, it's telling you have Rh factor. And Rh factor is another type of antigen on the cell surface. Okay? So, Rh positive means you have the Rh antigen on the RBC. Okay? So if I said this blood right here was A positive, not only did it have the A antigen, it also had the Rh factor on it. Okay, good. Now, if it has Rh factor on it, is it going to have antibodies to Rh factor in the plasma? No. Good. All right. So if we had Rh negative blood, that means we don't have any antigens on the cell surface, correct? Give you a second to process it. Yes. Okay, good. Now the difference with Rh factor is that does not mean you're going to have Rh antibodies in the plasma. Okay? So that's another key component. Just because you don't have Rh antigen on the blood does not automatically mean you will have Rh antibodies in your plasma. For the A and the B, it did. If I had A antigen, then I definitely had B antibody. Okay? And so when we got here and we said we don't have either one, so we have both antibodies. So if I say there's no Rh factor, your first thought would be then it's all right to have Rh antibody, but it's not automatic. We don't have it normally. Okay? So generally we don't have Rh antibodies. We can make them, okay, and I'll show you what happens there with that. Is everybody following that? I'm going to give you a little scenario, and hopefully we'll see, okay, I get it. Some of you won't, but I don't know if you'll raise your hand to say that, but that's what we're heading to. There's a thing known as erythroblastosis fetalis. also called hemolytic disease of the newborn. And this is a hemolytic disease, meaning blood hemolytic lysis disease that happens to newborn babies, or can. Okay? And it's due to an Rh incompatibility between the mother and the fetus. Okay? So, where'd my marker go? So, if I have mom's blood right here, all right, and mom is Rh negative, all right, I don't care what we have. We'll say she's, you guys probably can't even see this damn marker, O negative, okay? So what antigens does she have on the cell surface? None. What antibodies does she have in the plasma? A and B, but she doesn't automatically have Rh, right? Okay. So mom has a baby. Dad was Rh positive, and the baby turned out to be Rh positive, okay? So there's some mixing of mom's blood and the baby's blood at birth. So now mom's blood sees Rh factor. Has it ever seen it before? So it's going to think it's foreign. So what do we do? What's the body going? How's the body respond to foreign things? Yeah, it doesn't like it. So it doesn't attack the first one, but what it does is it makes, now it's going to make Rh antibodies to it, okay? And then if mom has a second baby, and that baby has Rh factor, now mom's blood has antibodies, and that's going to be a nightmare, okay? That's not going to work. So that's what the hemolytic disease of the newborn is, but what do they do to prevent that? They give you a shot of RhoGAM, okay? Because this is very preventable. All right, so in this country, we don't even worry about it. I don't even think, typically you don't need to give a RhoGAM shot to you unless it's your second child, but it's so cheap and it's so whatever that I think they just give it all, any pregnancy, they'll give you a shot of RhoGAM just to prevent this. So it's treatable but also preventable, okay? And it happens with an Rh negative mother whose first child is Rh positive. And it's simply mom's blood gets introduced to Rh factor. Says, what the hell's that? I don't like it. I'm going to make some Rh antibodies. And then when she has the next child, if it's Rh positive, then you got a problem. The blood's going to agglutinate. Okay? So let's see here. We got a question. Let's see how we're doing on this. If you have A antigen on your RBC and no Rh factor, what type of blood do you have? Think about it for a second. You don't have to spit it out yet. Let everybody maybe process it. How many think it's the number one, type A negative? You guys got it right. I'm assuming the rest of you weren't going to vote. Were any of you thinking something else? Do we need help? No? We weren't going to vote. That's what I figured. All right. So we get that. Here's that process. So we got mom Rh negative, baby Rh positive, first child, first pregnancy. Okay? And there gets a little bit of hemorrhaging during delivery, blood mixes a little bit, mom's blood gets to see the Rh factor, says, whoa, I don't like that, and makes antibody. Okay? Everything's fine, but mom gets pregnant again. This time, mom's blood's antibody attacks the antigen on the child's, baby's blood, fetal blood, and we get the agglutination. Okay? So that won't work. So they type this blood in order to give transfusions. So when you give blood, they type it so they know what to give or give it to somebody else. They ultimately like to give matching blood to somebody who needs it, okay? If they can't give matching blood, what do they give? What's the universal donor of blood? O negative, good. Now, oftentimes when we are giving somebody blood, we're giving them just the red blood cells, just the formed elements, okay? So can you see why O negative would be the universal donor? If all I'm giving you are the cells, their cells have no antigen. So it doesn't matter what the recipient's blood has in it for antibodies, there's nothing to attack. Does that make sense? Okay. Who then would be the universal acceptor, could get blood from anybody? AB positive. Okay? Because AB positive had both antigens and was Rh factor positive. So they don't have any antibodies to anything. So once again, you could give them whatever, and they'd, for the most part, be all right. Like I said, they tend to like to give matching blood, but those things do fit. Okay? So blood typing, determination of Rh, ABO blood types. And this is real simple, how they type the blood. I think we're either adding that to lab this semester. We talk about so many things, I never know what we're actually going through with. But we're going to maybe type some blood. And the way you do it is you put a little drop of blood into 3 little dishes, okay? And then you drop in some antibody. If I drop in anti-A or A antibody in here and it clumps, what's that tell me is in there? A, antigen, okay? And then in the next dish, if I drop in some B and it clumps, what's it tells me is in there? B. If I drop in some anti-RH and it clumps, what's that tells me is in there? RH. Okay, and if it didn't clump, it'd tell me RH isn't there. So with those 3 things, I could type the blood, right? It's that simple. That's what they do. I don't think they're going to let you type your own blood. We used to let you prick your finger and do that, and then they didn't. I don't know. Students complained that it was being mean. Okay? A sample of blood is mixed with serum containing agglutinins to each of the major agglutinogens, A, B, O, and RH. Okay? And we basically determine the blood that way. Cross-matching, mixing a donor and recipient's blood for compatibility so that we don't get that clumping. That's really all there is to it. Now, normally we'd start a new unit. I'm going to throw this out there. I already know the answer, but this sets us up. We could have our test on Wednesday, or we could start new material on Wednesday from the next unit and push our test back to Monday. How many want to push the test back to Monday? Holy shit, I didn't see that coming. I had no idea you guys would want to do that. Okay, so that's what we'll do. And just, by the way, somebody sent me an email, which is cool. I'd rather you always check than assume. But if we don't get through the note packet, I don't care what your schedule says, we won't have the test until we get through the note packet, okay? So don't ever panic like, oh my God, it says there's a test today, but we didn't get through the note packet. We didn't get through the note packet, there won't be a test. Now, I'll give you a breakdown on the test. Wednesday, we could still have a quiz over this, just so you know. Wednesday, we'll start new material, I think it's respiratory system or whatever, which won't be on the test. I'll get you out your new packets or whatever. Don't forget the pathologies, okay, on your objective sheet. Some of you maybe already done them. You know, you can do them, share them with each other, do half of them, share them, whatever. That's not cheating, that's working efficiently because there's quite a few of them, all right? I can't think 201, their last test, they forgot they were on there. So that didn't go so well for them. Let's break this down for you.